Hi dentists, how are you? This is Mohammed Musa from AFK Study Plan. Today we are going to continue our journey with the articles from NDEB website. As usual, bring your notebooks, your pen, write your notes, and try your best to answer the question which will come to your screen. I think the question will come at the interval of 10 to 12 minutes. Try your best to answer this question, and for sure feel free to share these articles and this video with other dentists going to exam or trying to challenge AFK exam. Leave a comment for me of anything that's not obvious for you or you need more explanation about it. And with that being said, let's go deep in this article. So this article explaining about the new system of caries classification. It's International Caries Classification Management System. To be short, it's ICCMS. This new guidelines has been studied for maybe recently 4 or 5 years in the Canadian University. Honestly, dentists from outside Canada, I think they have no clue about this one. And this system, when you think about it at the first glance, you feel like, oh my goodness, they're so sophisticated. But this system is here to overcome some problems in the caries classification we have it now. So let me give you example. Like if you have a patient and this patient has a class 1 cavity, just class 1 cavity, and this just occlusal for 4-6, and his age is maybe like 25 years old, and you feel you cannot deal with this patient, so you refer him to another dentist, and the other dentist asking you which tooth need to be restored. You told him it's 4-6, and then you said it's only class 1. When the patient go to the other office, the dentist will think about, okay, class 1, so he would think this may be a small cavity on the occlusal surface, the fissure, maybe it's deep, maybe it's close to the bulb, maybe this patient has other caries need to be done, maybe this patient has the buccal bit also, maybe this patient has more caries need to be explored, maybe this one is exposed, need root canal treatment. So our system, our current system, does not address any of this all. And the new system is trying to give you a guideline which you can follow. Each tooth, we are going to give it a score, and this score will reflect the caries activity level, the caries risk for the patient himself, the x-ray radiograph, what you see in the radiograph. So when I tell you this tooth has this code, so you think, okay, this x-ray will be showing this, the cavity showing is extend into dentin or just enamel, the cavity is active, the caries is active or not active, so you have a better perspective of the condition, and then for sure you will have easy time to detect the problem and give the patient the proper treatment he needs to get rid of the cavity and get rid of the caries. So, in short, ICCMS is a health outcome focused system that aims to maintain health and preserve tooth structure. Staging of the caries process and activity assessment is followed by risk adjustment, preventive care, control of initial non-cavitated lesion, and conservative restorative treatment of deep dentinal and cavitated caries lesion. So it's not like caries classification, class 1, class 2, class 3. No, it's a complete guideline which you can follow. So our goal in this articles for you at the end of this article or this video, for you to know the classification caries, stage and activity assessment, management, personalized caries prevention and control, tooth preserving operative care. So for you at the end, you should know this guideline. So this is the big picture. So we should dig deep in this one. Like I love to begin with end in mind. So this is what you need to understand by the end of the video. So I would like you to go back after you finish it and go in here and you see, okay, now I understand what this mean of sound or initial or moderate. And then you understand this 4 or 5 or 6 and obvious decay, no obvious decay. So at the end, you should understand this graph and you know what you are doing about this one. Before we start, this topic has been asked in the AFK exam cycle, maybe maybe 4 question, 5 question in each cycle for the last few cycles. And I vividly remember like I advised some people taking the cycle, not the previous cycle, the previous one. I told them like this topic is important, please try to study it. And one dentist like she told me like that this item or this topic has no question in the previous cycle, and that was her like point of view not to study it. Honestly, I hate this like idea about studying for it, this exam. AFK exam is assessment of fundamental knowledge. Articles are important. Doesn't mean like because the last cycle has no question about this topic, I will just not read it or I will not study. Or the previous cycle has no question about the perio classification, so I will discard this one. Or the previous cycle has no question about the palpatomy or pectomy, I will discard this one. Let me tell you a secret about AFK exam. The AFK exam usually, and you can ask your friend who did this exam before. You will be faced with like exam centered about certain topics, and I will not be lying if I'm telling you, like if you think about pharmacology, you will be faced by like 4 or 5 questions coming from one chart. You will be challenged with three management, clinical management, speaking about asthma. You will be asked about diuretics, 3 4 questions back to back. You will be asked about diabetes mellitus drugs, 3 questions back to back. You will be asked about palpatomy or pectomy, 3 4 questions back to back. So either you can navigate the 3 4 questions and get them all, or if you didn't study it, boom, you are done. These 3 questions are, you lost them for nothing. So when we speak about the articles, I know what I mean. It's extremely important. Even if the previous cycle has no question about it, it will be asked again. It will be frequently coming. And this it's not like I'm a magician telling you a secret. You can ask your friends who did this exam before. The articles are important, and you will be faced with some question from almost every article about the consents, about the epidemiology, about the maleficence and autonomy, stuff like this. You will be hit. If you know nothing about it in the exam, you feel like, oh my goodness, what this? If you know it, trust me, it's super easy to answer everything. So, as we discussed before in the trauma management and we discussed before in the caries management, the new guideline is not to think about this cavity I need to fill. No, it's like a complete approach to diagnose your patient in every level. So, first step to be done is history. Patient level caries risk assessment is the first step that you need to do before you dig deep in everything. And if you think about it, you feel like, oh, this is absurd. Like, I need to just fill his tooth. No, you will understand why this is important. Okay, so caries risk level assessment is very important. And as we speak about before in the perio classification, we will think about our patient to be moderate risk, unless we have a clear evidence to push the patient in to be a low risk or to push the patient to be in a high risk factor. So list here is giving you the risk which will put your patient in a high risk factor. This include, but not like exclusive to, head and neck radiation. If your patient has a therapy for head or neck radiation, this will affect his salivary flow. It will be less. When saliva is less, caries flourish and caries progress in the teeth very fast because like saliva is act as a buffer against the caries activity. As well as dry mouth condition or medication or some drugs doing this one. Inadequate oral hygiene practice, for sure, if patient is not brushing his teeth, that your patient has no knowledge about the floss or he even didn't use floss ever in his life. Deficient exposure to topical fluoride. This include in the office and in the water fluoridation, high frequency amount of sugar drinks, snacks like for kids in the school, symptomatic driven dental attendance. Like this mean like patient coming to your office in emergency basis only. He's not coming to do his hygiene. Socioeconomic status, health access barrier, or for children, high caries exposure of mother or caregiver. If you feel like you are a little lost here, I will put the link here for the article we speak about the caries risk assessment. You can watch this video. I think it will get you on track on for this article, and then you can come back to finish this one. And then there is some risk factor also will give you more privilege that you think, okay, this patient, we can consider him as a high risk, not a moderate risk. Plaque assessment is essential for intraoral caries risk determination, but plaque has to be removed for accurate caries staging and lesion activity assessment. The assessment of caries will always be conducted by means of visual examination and, when possible, combined with radiographic examination. So we never say this cavity extending blah 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 dental enamel or stuff like this without the use of x-ray, because like you can detect the extent of cavity if you think about the occlusal surface. But when you go to the tricky part like the proximal surface, visual examination or even with a probe is limited. Like it will give you limited information. X-ray here is the main factor. This will lead to information about the stage of the caries in terms of initial, moderate, or extensive, and its activity in terms of arrested or active. What does this mean? So before we go more about this one, let's also speak about intraoral liver caries risk factor, which means there is some risk factor. When you see it intraorally, you think, okay, this patient, we can push him to be in a high risk, like hyposalivation, gross indicator of the dry mouth, BUFA, like it's mean exposed bulb, ulceration, fistula, or abscess, dental sepsis. Like think about it. If your patient has lower six with exposed bulb, or he has ulceration or fistula or abscess, so for sure this patient will go to the high risk. Caries experience an active lesion, thick plaque, evidence of a sticky biofilm in plaque stagnation area, like in the occlusal surface, you see a lot of plaque, or even in the cervical part for the posterior teeth, appliances, restoration, and other causes of increased biofilm retention exposed root surface. So if you see any of this like factors inside your patient mouth, so you have good evidence to push him to be in a high risk. You cannot say this patient has a moderate risk for caries. Okay, so this is the bottom line. Here we speak about the moderate risk. Moderate risk, a stage where the individual is not deemed to be definitely at low risk or definitely at high risk of developing a new caries lesion or of lesion progression. Low risk, a lack of any high caries risk, like the red text we speak about, and other risks are within safe range. Sugary snack, oral hygiene practice, and fluoride exposure. It's not the optimum, but at least he is living in a community with water fluoridation. He's not using sugary snacks more frequently, as a frequency is more important than the snack itself. He's trying at least to brush his teeth. He's coming to your office to get the hygiene, even not in 3 months interval, maybe if he's like stable patient in 6 month interval. So this patient is following your regimen, so you can say this patient has low risk. And for sure, the high risk status, presence of any of the high risk factor in box one, we speak about it, or caregiver with very high caries experience, or where the level of several of low risk factor in box one suggests a combination likely to lead to high risk status, meaning like you can see not a high risk factor, but like more than one factor which will be pushing you to put this patient in a high risk factor. I hope this point is clear for you, because this is important in the management of the patient later. And again, you can go back to the article speaking about the risk factor. We speak about it in details. You will find it honestly beneficial in this topic. And then we going to do staging. Staging of caries lesion involve two steps of caries diagnosis process. First one is lesion assessment, and second one is lesion detection. Assessment aims to characterize or monitor a lesion once it has been detected. Like when you see a caries lesion, so you should monitor it and say, okay, we take x-ray for this one, and you describe the lesion, how it was in your first visit, and then how it was like going more after 3 months, after 6 months, after 1 year. A lesion detection implies an objective method of determining whether or not caries disease is present. So meaning we're gonna look into the tooth by visual examination, and this visual examination will give us a hint about the caries here. And this was the only criteria we used to do before in the caries classification. Here, this is just a step in the caries classification in this system. So first of all, it will be sound surface. As you see here, the tooth has nothing wrong. There is no discoloration, nothing. Sound tooth surface show no evidence of visible caries, no change, and the enamel is perfectly clean. Nothing is good, nothing is like even suspicious about this tooth. And the good condition or the perfect condition you're aiming to get the correct diagnosis for you to view the tooth clean and after prolonged air drying at least for 5 seconds. Why this is important? Because like if the tooth has a cavity, Sometimes it's a small cavity. When the tooth is wet, saliva go inside it. And when saliva go inside the cavity lesion when it's present, it will give you a frosty white appearance. When you see in the picture, you see it's the enamel is well polished, everything is good. So if this tooth, the same tooth, has a cavity, which is not cavitated, just initial lesion, but this initial lesion will be frosty white. When the saliva go and make it wet, when it's wet, it will be shiny again, so you will misdiagnose this one. So it's strictly recommended you view the tooth which is clean and after prolonged dry air for 5 seconds. And for this Caries system, we are going to ignore other reason for change in enamel, like surfaces with developmental defects such as enamel hypomineralization, fluorosis, tooth wear, like attrition, abrasion, erosion, extrinsic or extrinsic, that will be stained recorded as sound. So we are not here to discuss developmental defect. We are here to reach an agreement that okay, we have a system for caries only. We don't care about this stuff in this point of view, not like we don't care about as a dentist, but in this point of view. And then we're gonna speak about the initial stage. When you look at this picture, especially the occlusal surface, I think now you understand what I mean about the frosty white. You see in the occlusal surface and the fissure area specifically, you see it's white but like it's frosty. And this is the first or distinct visual change in enamel. Think about this tooth if it's wet. If it's wet, you cannot see it. So that's why it's extremely important to make sure your tooth is dry. Seen as a curious opacity or visible discoloration, white spot lesion and or brown curious discoloration. Not consistent with clinical appearance of sound enamel. For the previous code, it's code 0, and which show no evidence of surface breakdown or underlying dentin shadowing. So in this one, we're gonna give her code 1 or 2 when it's just a visual change. You cannot say there is physical destruction of the enamel. It's just a visual change that you can detect with your eyes, but there is no loss of tooth surface. There is no loss of enamel. Just initially, there is no enamel breakdown in this one. And I think you can understand it now. We're gonna give the caries code 3 or 4 when you see localized enamel breakdown without visible dentin exposure or an underlying dentin shadow. Meaning, like, think about the bottom picture, you see a discoloration. This discoloration, if you go with a blunt probe, and this is important also, when you do your visual examination, you use a blunt probe. You are not going to use a sharp probe. Why we don't use a sharp probe? Because like think about this one, the frosty white. If you use a very sharp probe in this frosty white, you're gonna break it and you're gonna initiate enamel breakdown. So that's why we're gonna use a blunt probe. For the blunt probe, it's gentle. It will not break the frosty white. Or it's gonna be like, it's going to be shown as a top picture when you see discoloration and you don't see dentin by itself, you just see underlying dentin shadow. So code 3 and 4, there is enamel breakdown but no exposed dentin without visible dentin exposure. You can just say, I see a shadow. And here to confirm enamel breakdown, a WHO, CPI, PSR pole end probe can be used gently across the tooth surface. A limited discontinuity is detected if the ball drop into the enamel microcavity discontinuity. Meaning like when you have a gentle probe, rounded probe, and it catch, this means you have a cavity here, you have enamel loss here. If it's sharp probe and you go to frosty one, it will break it. So this is code 3 and 4, and we call it, it's a moderate cavity. And then if you have a distinct cavity, opaque or discolored enamel with visible dentin. When you see the dentin, okay, so now we consider this one as extensive stage. We're gonna give it code 5 and 6. You're gonna be confused like why we give code 5 and 6. When we say 5, when we say 6, we're gonna discuss this later, but this one, just to give you overview, when we're gonna say it's initial or moderate or advanced or nothing, or extensive or nothing, okay? And then here we speak also about this one in the caries management before, but let's confirm it again. Clinical investigation in a country with low caries progression rate revealed that on average 32 of radiographically visible lesions that extend into outer third of dentin manifest cavitation. So if you take X-ray and you see a radiolucency enamel extending into dentin, they found clinically it's only 32% of this patient has a cavity inside the dentin. In contrast, 72 of lesion extended into inner two-thirds of dentin were cavitated. So to wrap it for you, when you see X-ray and you see in this X-ray radiolucency enamel extending to the outer third of dentin, it was cavitated only in 32%. And if the radiolucency extending into inner two-thirds of dentin and 72%, it is cavitated clinically. Clinically cavitated lesion or lesions with obvious dentin radiolucency deeper than outer third on the occlusal surface are heavily infected in the dentin beneath the enamel dentino junction. So this study giving you idea like if the radiolucency extending only to the outer third of enamel, so you think okay, it's like 1 out of 3 this tooth has a cavity in the proximal surface. But if you see it extending into inner two-thirds of dentin, so it's like 2 out of 3, like 72%, it's really cavitated and it needs to be restored. So, and this will be reflected on the line of treatment. We're gonna choose it later. So, and then we're gonna speak about the second factor is the X-ray. So first of all, we're gonna give code 0 if there is no radiolucency. It's a perfect tooth, no radiolucency, you see good enamel, good dentin, everything is good. And then we're gonna give it code initial or moderate or severe. And we're gonna think about it, it's so easy, like think about it in this way. We're gonna think about the enamel to have two halves, like it will be outer half and inner half. And dentin would have 3/3, outer third, middle third, inner third. And as we discussed before, as we said, if like think about RA3, we said if the radiolucency is extending in the outer third of dentin, it's only 32% of patient has a cavity. That's why we gonna categorize this one as initial stage, and that's why you see R as radiograph, and we gonna give letter A, which is like the initial stage A, and then we're gonna say 1 if the radiolucency in the outer half of enamel. We're gonna say it's 2 if the radiolucency in the inner half of enamel with dentino enamel junction or without dentino enamel junction. And then we're gonna say it's RA3 if the radiolucency is limited to the outer third of dentin. And I hope you understand it now why the radiolucency inside the dentin and we still call it as initial stage. Okay? And then I think you can conclude this one. Moderate stage if the radiolucency reaching middle third of dentin, a second third, and we said clinically this one 72% will be cavitated. That's why we're gonna say it's a moderate one. We're gonna give B as a letter and 4 as a number. So it will be RB4. And then we're gonna say the last thing is extensive. It's into dentin, into the inner third of dentin. We're gonna say this is RC as the third extensive, and we're gonna give it code 5. And if you see the radiolucency is reaching into the bulb, you're gonna say it's RC6. So it's A, B, C. A will be 3 letters, 3 numbers, 1, 2, 3, and B will be just 4, and C will be 5 and 6. And now you need, I think you are lost now, so I think you need to combine everything together to reach a diagnosis. So let's look at this beautiful graph. Honestly, this article is amazing in term of the visual. They have a good tables, good radiograph, good visualization. I would recommend you to go to the articles. I will provide you the PDF, which I did highlight the important part. You can for sure get a copy of this presentation and also the PDF. I will give it to you. Okay, so we're gonna say let's go for the horizontal matrix. It's R0 or RA1, 2, 3 or RB4 or RC5 and 6. And you see the diagram here. RC0 is nothing. Sound there is no change. RA1 or 2 we're gonna say is initial. RA3 is still in initial. RB4 extending into second third of dentin. R5 RC5 and 6 extensive caries. And then this will reflect how you're gonna deal with it later. So this is a horizontal matrix, and the vertical matrix is going to speak about its sound or initial or middle or extensive. I think you still remember sound will have code 0, initial will have code 1 and 2, moderate will have 3 and 4, and extensive will have 5 and 6, which is going to be reflected, I think, the same as a radiograph. So when you see it here, so when I tell you it's extensive RB4, so you go for horizontal matrix and you say this extensive caries. When I say this is initial RA3, so you think it's initial or moderate caries extending into the dentino-enamel junction or the outer third of dentin. So when you think about this matrix, when you have the code, so it's not like class one and you have no clue about it. No, it will be evident for you. So the tooth will have two codes, one for the initial or moderate or extensive, and one reflecting the radiographic change in the tooth. And then we're gonna speak about the second factor is characteristics of lesion. We said we are going to detect the lesion and then we're gonna like describe the lesion. So the lesion has only two scenarios. It's either an active lesion or inactive lesion. So usually the active lesion or inactive lesion, it will be initial, moderate, or extensive. So you need to check the criteria for everything because you will be faced about the question giving you, he's saying like this tooth has a cavity extending into this part and it looks like, so extending into the dentin enamel, so you can conclude the number, which is the previous slide, and then he was going to describe the caries lesion for you. So this description will be fit in this matrix. So for active lesion, surface of enamel is whitish yellow, opaque with loss of luster, feels rough. This is important, feels rough. As we mentioned in code 1 and 2, you see there is no breakdown, but it's rough. When the tip of the ball-ended probe is moved gently across the surface, lesion is in a plaque stagnation area. What this mean? This means the entrance of patent fissure near the gingival margin or the proximal surface below or above the contact area. This area is like, think about it. This is the area when we have plaque. When we have plaque, like staying on the tooth for a long time, it will induce caries activity. And this patient usually will have, or this location will have thick plaque barrier to cleaning. So if you see all these criteria, you say, okay, this lesion is active. This lesion is active. When you're gonna say it's not active, surface of enamel is whitish brown or black, meaning it's not white or yellowish. This is more dark, it's brownish to black. Enamel may be shiny or feel hard and smooth when the tip of the ball probe is moved gently across the surface. And again, it's a rounded one, so you don't have a risk of breaking the enamel. For a smooth surface, the caries lesion is typically located at some distance from the gingival margin. Lesion may not be covered by thick plaque prior to cleaning. So to cut short for you, if it's active, it will be rough. It will be in area of plaque stagnation area. You will see a plaque around the tooth surface. If it's going to be more brownish to black, shiny and feels hard and no catch for the probe, no sound for the probe, you're gonna say, okay, it's inactive lesion. And then the extensive lesion is speaking about dentin for sure. So dentin feels soft or leathery on gentle probing, or dental is shiny and hard on gentle probing. So let me give you a simple example. So if I'm telling you, you have a patient with 1.6, and you look into your mirror and you see a cavity. This cavity has a breakdown of enamel and you see exposed dentin, which is soft and leathery. So which code you're going to give to this one? Pause the video and think about it and give your answer. And then if the same criteria, but this tooth has a shiny hard dentin, so which one you're gonna give the code for this tooth? I hope this is clear for you because this is critically important, okay? And then this is the two factors we speak about it. So we are going to speak about it as complex, combine it together and give you the answer. So as I give you the example, you will be faced with a question saying this one. It will describe it as extent into dentin enamel and describe it as activity, as character, soft, hard, discolored, whitish, shiny, leathery. So you think now you can understand that concept and apply it to the question, and then you can get the answer very easy. Okay? Then the clinical application. So after we did all that, you have the caries risk assessment. You did it for the patient. You say it's moderate, high, or low, and then you describe the tooth surface and you describe the extent of the cavity and you describe the activity of the caries itself. So we are going to combine it together. So let's speak about the horizontal matrix first. No active caries lesion or initial active or moderate to extensive active. So if your patient is low risk and no active caries lesion, so he's a perfect patient, give him a toy, let him go home, and ask him to continue whatever he's doing in his diet, in his fluoride application, in his oral hygiene regimen. He's doing amazing, so he's good. If your patient is a low risk, doing everything, but you see initial stage active caries lesion, so pay attention, initial stage active, which means there is breakdown of enamel with the enamel being whitish and not hard. It will be rough. So you say it's a moderate likelihood or extensive stage. Even if it's low risk, you're gonna say it's moderate likelihood because this patient is still in a low risk. And as you go down, you can think about it. Moderate risk, you will be less forgiving with him. If he goes with moderate, you're gonna say it's high likelihood. If it's high risk, you're gonna start if even no active caries lesion, you're gonna say it's moderate because he has other factor make you believe he is at a high risk. So you need to go with more aggressive oral hygiene measure for him. Okay. So what oral hygiene measure you can give to the patient? So before we go to this one, we're gonna conclude here the management. So we speak about the history, we speak about the how we gonna give its staging and activity, how we gonna determine this one. So the management. Now we can reach to the management part. So the management, as specifically mentioned here, is a personalized caries preventive control and tooth preserving operative care. So there is no solution fit everyone. So even if you have patient with different activities, but he has different risk factor, so they will have different line of treatment, they will have different frequency. That's why it's important to go hand in hand with the two factor, caries lesion and activity but tooth surface and the likelihood for new caries to be here. And then you're gonna speak about the three factor, the higher moderate risk, and then you speak about initial, moderate, or active. I'm repeating this again and again because I want you to understand the concept, not to memorize answers. Okay? So here is the guideline. And the guideline, this guideline is extremely important. You're gonna be faced with question in this in AFK, ACJ, and trust me, you are gonna face some question about this in the situational judgment when you go to practical. Even if you go to the last exam, you will be faced with this question. They love this article so much, and they know most of us know nothing about the system, so they love to ask about it. So for patient with low likelihood, you're gonna give him the basic recommendation: tooth brushing twice daily with a fluoridated toothpaste. You would recommend more than 1000 ppm fluoride, following the dental team instruction, which you're gonna giving to him, like flossing, this stuff you are going to give every patient. And then as story goes on, you are going to add more. So it doesn't mean like a moderate likelihood you're gonna give him this only without this part. No, he's repeating and adding more. Tooth brushing twice daily with higher efficiency fluoride toothpaste. So the toothpaste is more than 1450 part per million fluoride, or high fluoride prescription toothpaste, following the dental team instruction for sure. And then you're going to give him more instruction about general behavior modification and oral hygiene, which include caries risk assessment, which will include dietary consultation and the frequency of the high sugar intake he's doing, especially if he's a kid, and prescribe fluoride mouth rinse. You give it to the patient, and this all is under the home care. This is what you are going to tell your patient to do in his house. And then we are going to speak about the fun part, which is really important for us. So what you are going to do clinically. So it's for every caries risk, low, moderate, high. You are going to give him motivational engagement, discuss with patient how to improve oral health behavior, including amount of sugar, maintain dental visit at risk-based interval. And I know a quote, it's amazing. Like, you don't have to brush all your teeth, only the one you want to keep. It's like you are going to be little funny with the patient, trying to give him like a good example of how to take care of his tooth. Ask him gently to show you how he's brushing his teeth. Maybe he's doing it in a horizontal way. So it's you remember the house serious when the patient said like I'm using the inhaler 3 times every day and it's not working, and she was using like snot inside the mouth. So I know it's a little funny, but it happens with some patient. He's telling you I'm brushing my teeth very hard, I'm doing everything, and he's a heavy smoker or he drink alcohol a lot, or this patient has higher risk caries assessment, like he has previous history, or this patient has active caries that didn't receive treatment for 2 or 3 years. So it didn't work this way. It's not like one solution fit everything. So it's a whole management for everything. And then you are thinking about sealant if it's moderate to high risk, for varnish 2 times every year at least for moderate to high risk, gel of fluoride solution. It's that it's like fluoride application, but like it's a gel. You give it in something. It's looks like the mouse guard, but it's foamy. You put it and leave it inside the patient mouse for a few minutes. Recall up to every 3 months, professional cleaning and topical fluoride application. Motivational interviewing, you speak about the patient. One-to-one dietary intake intervention. Alternating medication-induced hyposalivation for patient have this problem. Reducing the use of recreational drug. And then for the high risk, you are going to increase the fluoride varnish to be 4 times every year. Topical fluoride with high frequency than the moderate risk. So I hope you understand it now. It's a scenario and a story building up. It's not like one solution for everyone. So now we are going to wrap everything up and put it in one matrix to get the conclusion. So after you do the staging and you determine it's active or inactive, you are going to combine it together and see in a horizontal matrix if it's pit and fissure area, mesial or distal, or smooth surface. So it's sound, you do nothing. You do risk-based prevention, and that's it, giving him instruction and send him home. So if it's initial, but it's active, it's code 1 or 2, but it's active, it's rough. So clinically applied topical fluoride should be done. Oral hygiene with fluoridated dentifrice should be provided, like you give him fluoridated toothpaste more than 1000 part per million. And then mechanical removal of biofilm, which means the hygiene. So, and if it's pit and fissure, you may use resin sealer. It's mesial or distal proximal, so you can use resin-based sealant infiltrate. Resin infiltrate is a material that you use to control the active initial lesion in the proximal surface. We can discuss this in a different video because it's a different topic and it has different indication. If it's initial inactive, nothing, no lesion and specific treatment to be done here. Okay, and then we go to the next stage to be the moderate stage. If it's moderate and inactive, you should intervene here. TBOC, like NDEB love this fancy terminology, tooth preserving operative care, which include like you are going to do a cavity. You're going to use your hand piece. You are going to use your excavator to remove the caries and try to fill it with a filling material, or resin-based sealer. But resin-based sealer for moderate active is like not recommended, because you know resin sealant is like it should be not very thick in the area. Like if you make it very thick, it has like almost no efficiency. Mesial and distal, determine cavitation. For appropriate management option, teeth separation recommended. And he's saying like if you feel like, as we mentioned before, the radiolucency extended to the outer third of dentin, only in 32% will be cavitated. So at which phases you say, okay, I'm going to use resin infiltrate here, or I'm going to use full filling for this patient. So you may freeze him, put like, you know, the big wedge to separate the tooth, and then check it with your probe. And in the free smooth surface, moderate active, you are going to intervene for sure to do dental treatment here, full cavity and removing and put the filling material. And as I believe in moderate and extensive, active or inactive, you are going to intervene anyway. Extensive active, you are going to intervene with a filling material. If extensive inactive, you are going to think about it. If it's in aesthetically unacceptable area, you're going to intervene. Or in area with a plaque stagnation, you are going to intervene. When you are not going to do a treatment, if it's moderate inactive, no treatment. Or TBOC, if the lesion become a stagnation area, like the lesion is in the area where you have more plaque and you see a plaque over this occlusal surface, so you say this patient is high risk, so you are going to intervene and give him a treatment. You are not going to let him go home and come back to you after 6 months with a tooth with a huge cavity. Okay? I think that was all for this one. And here speak again about the primary dentition, giving you the same criteria. There is no difference between this one and the other one. It's the same criteria anyway. If it's moderate active, you are going to intervene. It's moderate inactive, you are going to do surveillance for it, and you do a recall frequency more, and you're going to reinforce more about the oral hygiene measure. But for the primary teeth, it's moderate, you are going to intervene anyway. And I think you can know why, because the primary dentition is like has a small enamel layer and big dentin, and the dentin is softer in primary teeth, so the progression of caries is much faster in the primary dentition than permanent dentition. So you are going to intervene. It's active inactive, as it's moderate to extensive. You are going to give him a treatment. You are not going to wait for this tooth, because it's important for the permanent dentition to be in place. So after all we speak about it, we speak about the history, caries risk, we speak about classification, and we speak about the staging of the caries depend on the visual examination and x-ray, and then we speak about activity depending on the appearance, color, and texture of the lesion, and then we speak about the management. Then we come to decision making part, which is the outcome. So it's like as we say, it's a full approach. Outcome is health maintenance. Health maintenance, you give the patient a instruction to follow at his house, or to come to your office at the interval you diagnoses with him about the caries risk. And then disease control, when initial caries to remain unchanged or reversed, initial to moderate caries to be managed effectively in the office, and clinical and radiographic detection for the region for progression controlled tooth structure preservation, and the patient-centered quality matrix, the patient satisfaction with the dental status of the health, and education for the patient, and finally wider impact of ICCMS. They want this guideline to be implemented for everyone and link it to different educational institute and all over the world to accommodate this new guideline and think about it. Finally, ICCM guide is about 4 steps. First step is about the history. You take the history, you check the patient risk, and then you are going to use your visual examination and using x-ray to classify your cavity, to have a stage and activity of level of activity, active or inactive, and then you are going to tailor a guideline for this patient, and then you are going to give a decision for this one between risk assessment or just monitor this tooth, or intervene giving it a treatment which can be maybe bit and fissure sealant or a filling or resin infiltrate, and finally follow up and this patient come back to your office and make sure he has a good treatment and following your oral hygiene measures. I think that was all about this article. I believe it's easy. You just need to understand the concept and apply it. You read the question, you think about the criteria he's giving you in the question. There will be nothing missing. You just need to read the question carefully to understand it and then apply your answer with the knowledge you have from this article. Feel free to share this video with other dentists going to exam. Leave me a comment if something is not clear for you, and have a good day.